Good afternoon, everyone. My name is Dr. Jodie Guest. I'm an infectious disease epidemiologist and professor and senior vice chair at the Department of Epidemiology at Rollins School of Public Health here at Emory University. I also lead Emory's COVID-19 outbreak response team, and I'm the host for Emory's COVID-19 videos, where we talk about important topics of this pandemic. Today, I'm pleased to be joined by my friend and colleague, Dr. Carlos Del Rio, so that we can update you on the most recent information about the COVID-19 boosters. Dr. Del Rio is Distinguished Professor of Medicine, Epidemiology, and Global Health at Emory, and is the Executive Associate Dean of Emory University School of Medicine at the Grady Health System. He's also well known to all of you. Welcome, Dr. Del Rio, and thank you for joining me again today.
Happy to be with you.
Thank you. Quickly, here's a look at where we are with COVID-19 across the United States. COVID-19 cases and hospitalizations continue to fall across the country, which is very good news, with more than 30 states seeing declines in the past 2 weeks. However, there are states that are still seeing increases, and Georgia is currently leading that with the biggest increase in cases in the past 2 weeks, with a 40% increase. Currently, there are still more than 400 deaths a day being reported in the United States from COVID-19, which is still way too many deaths. Across the United States, 67% of the population has received their first series of COVID-19 vaccinations, while only 33% have received also a booster. This varies quite a bit by age, with more than 92% of those over the age of 65 being vaccinated, and having received at least one booster is an additional 65% of that community. There has been a lot of talk over the past couple months about a specific Omicron-specific booster coming out for COVID-19, and now it is here. 1 week ago, the FDA authorized the first redesign of the coronavirus vaccines since they became available in late 2020. These new boosters target Omicron subvariants, and the goal is for the redesign to help elevate antibody levels in a way that restores the protection conferred by the initial vaccines against symptomatic infection in many people. These new boosters are made both by Pfizer and Moderna. Pfizer's is available for people as young as the age of 12, and the Moderna booster is for those 18 and older. Dr. Del Rio, we're going to start with what's really different about these boosters. They are something called a bivalent. And if you could just start by explaining what that term means.
Well, thank you. I think, a couple of things, as you mentioned, this is a different vaccine from the one that we have gotten accustomed to up to now. And it contains the original strain, like the other vaccines did, but it also contains a BA4, BA5 antigen. So it has two antigens. That is called bivalent because it covers two. To remind people, for example, the flu vaccines would typically take are trivalent because they cover 3 different flu strains, usually 2 flu A and 1 flu B. So here we have a bivalent. It has 2 different antigens in it. And the idea is that will give protection also against BA4, BA5, which is the most common strain circulating right now. Now, what's unique at this last ACIP meeting last week, when CDC approved the use of those vaccines, for the first time, if you look at their recommendations, they didn't say the words Pfizer or Moderna. They just say they approve the bivalent vaccines because they want to get away from specific data on a specific manufacturer, and we'll go into the approval process in a bit. But there is a little bit of a nuisance. So as you mentioned, they're approved for people 12 and older. However, you're between 12 and 18, you have to use Pfizer because Moderna hasn't been yet approved for that population. If you're over the age of 18, it doesn't matter. Either Pfizer or Moderna is a vaccine you can take. Now, there's the other boosters we had previously are no longer available. This is going to be the new way to boost people. So you can actually give the people need to get, if you haven't been vaccinated, you need to get your original series, your primary series with the original vaccines. Could be Pfizer, could be Moderna, could be Johnson and Johnson & Johnson, could be Novavax, right? You get any of those vaccines, and then you get a booster with this bivalent vaccine. As you mentioned in your presentation, one of my big concerns is that we don't have a high percentage of the population boosted, in particular the population over 50, which is the one that is at high risk of severe disease and death. So we really need to make an effort clinically and in public health to really target the people that really need to get boosted. When I got people over the age of 50 saying, do I need to get boosted? I said, absolutely. If over 65, even more, absolutely. But people are under the age of 50, I say, yeah, get it if you want to, but it's not really that important, because the reality is the protection offered for these vaccines is probably not going to be very, very good. It's going to help you some, but it's not going to be really a slam dunk.
Let's talk about how this bivalent vaccine was put together. So the companies that produced it, they retooled their shots with a lot of speed. We've seen this repeatedly with this mRNA technology, the ability to do this very, very quickly compared to other types of vaccinations and vaccines. The FDA only told the companies 2 months ago which formulation they wanted them to work with. And now we already see millions of doses delivered to states. So what is that process of retooling an mRNA vaccination?
Well, it's pretty quick. I think that, the mRNA technology is what I would call a play technology. Basically, you're changing your cassette tape. So you just take out one and you put on another one, right? You're just changing the protein. It's pretty straightforward. What made it be approved so then will be produced so quickly? I think it's money. I think millions, billions of dollars were given in order to produce these vaccines very, very quickly, because we needed them before the fall. Otherwise, it didn't make any sense. But one of the points that I want to make is that, I've heard many people say, well, for the initial approval of the vaccines, we got data on 45,000 individuals in a clinical trial, and for these vaccines, we got data on 8 mice, lab mice, whether they were immunogenic or not. What is going on? Why can't we don't have data in humans? And I remind people that this is no different than how we approve the flu vaccines every year, right? There's a committee from WHO that selects the strains that are going to go into the new flu vaccine. The companies then actually do the process, which is a much slower process, because many of the flu vaccines still rely on an egg technology. So you got to get the hens to put the eggs, and then you have to put the virus in there. You have to grow the virus, and you have to create the antigen, and then you have to create the vaccine. So the technology is much, much less flexible than the mRNA technology. And then the vaccine comes into the market, and the FDA and the CDC approve the vaccine without any data, quite frankly. I mean, in this time, we at least have data from 8 mice. For the flu vaccine, we don't even have that, right? The vaccine is approved just based on it's likely going to work. And, it's only retrospectively that we say, well, this year the flu vaccine wasn't a good match. It didn't work that well. Or this year, the flu vaccine was actually a really good match. It worked really well. So you don't really need data from clinical trials once you're making just changes in the antigen. What you'd say is, I don't worry about safety. What you worry about is efficacy, right? And we only will know that like we do in the flu. We'll know it retrospectively. We'll get together back in February or March, and we'll say, gee, this vaccine really helped us prevent, hospitalizations and deaths during the winter. Or we can say, that was a waste of money because it didn't do much. But we will only know that after the fact. So safety is not my concern. Efficacy is a bit of my concern, and just because I've seen the neutralizing antibody data, and you're not going to get a huge spike in your antibodies. You're not going to get a lot of protection. So you may get additional protection for against severe disease and death. You're not going to get much protection against infection with this vaccines. That is important because frequently people say, well, when should I? The calls that I'm getting right now is, when should I get the vaccine? And what I tell people is, if you got your last booster within the last 4 months, or you got infected within the last 3 months, wait. You don't need to get it right away. And in fact, there's a recent article in preprint from Dr. Fauci's laboratory suggesting that after an infection, getting your booster within 3 months, simply the B cells are not ready. It blunts the impact of the booster. So you got infected with Omicron in August, last month, wait until November. Now, somebody just recently, as I was driving here, somebody called me and said, I've never had it. She's a woman in her late 60s. I've never had COVID that I know of. I got my last booster in March. Should I get the new booster? Absolutely. Go and make your appointment and get it right away, because you'll probably get the benefit of, if you happen to get Omicron, the chances of you developing severe disease and death are going to change. So we have to think also of these vaccines as not just the only tools, right? We also have testing. We also have Paxlovid. We also have Evusheld. We also have Molnupiravir. So we got to think now of the multiple tools we have. You get these vaccines, you get infected, get tested, get treated. There's ways to, there's additional things you can do to decrease your chances of getting sick and then ending up in the hospital and even dying.
Absolutely. And it's so important that we take advantage of all those opportunities that we have to curb the outcomes that are bad from COVID-19. Let's go back to something you said a moment ago. The safety and the efficacy of this, the efficacy we will find out. The safety, when you say you're not concerned about it, it's not because we don't know something about the safety. It's because this was a change in the antigen, not about the change in the technology. And that's why you're not concerned about the safety, correct?
Correct. I think about it. Let me give you an example. I have, Goodyear tires in my car, and I get a flat tire, and the Goodyear tire is not available, but the guy at the store says, well, we do have a Michelin tire. And I said, well, no, I can't put a Michelin tire because my car is not going to be safe. It's a different brand, but if it's the same size tire, the same type of tire, it's going to work just as well. You don't do a testing to see if that's a safe tire. That's what's happening here. You're just changing the antigen, but you're getting the same mechanism. Now, the one thing that I do like, and I've talked to several people, including Dr. Ashish Jha at the White House about this, I want us to stop calling them boosters, because this is not really a booster. This is a different vaccine. We don't tell people that you're going to get your flu booster, right? Every year we say you're going to get your flu vaccine. So we need to get away from this terminology of boosters, and we need to talk about we're getting your COVID vaccination. And you saw over the weekend or Monday, the White House, in their press briefing said, we're going to give you an annual COVID vaccine. I think they're trying to socialize the concept of getting away from boosters. It may not be annual, it may be biannual, but I think getting away from the concept of booster and getting into the concept of a regular vaccine, just like we do for the flu, I think it's a very smart way, and it's a good way to think about this going forward.
I agree with you. Let's talk about why this timing is so important. We do have some modeling that suggests that there will be a fall wave that would peak around December 1. And so rolling out this new vaccine at this time is really meant to help control current infections and also protect against this future surge, which we should all want to do. Let's go back to what you were talking about a moment ago. Anyone is eligible to get this new vaccine if they have had their previous booster or vaccine series at least 2 months ago. Let's go back to what you were recommending about who should be getting it now and who is okay to wait.
Again, if you were infected with COVID within the last 3 months, wait until you've gone over those 3 months. So you got infected in late July, August, September, October, get it in late October, early November. If you got infected if you didn't get infected, you went through this whole summer without getting infected. You're one of the few people out there that hasn't gotten infected.
Right.
And you took your booster, let's say last March. Well, now it's April, May, June, July, August, September. We're 6 months out. Go ahead and get your booster. So you really need to really think about, and it's a little confusing because the CDC recommends that you wait 4 to 6 months after your last booster, but says nothing about infection.
Right.
And I think we need to put infection within the equation and thinking about when to get your booster, because we know from data, I've seen some very good data, that if you got infected in addition to getting vaccinated, so you now have hybrid immunity, you're pretty well protected for 3 months. But not only are you pretty well protected, if you get a booster during that time, it's not going to do anything. So you might as well throw it away. So why run to get a booster if you don't really need it?
Now, if someone has not gotten any of their initial series of vaccinations, or at this point in time, can they start with this new bivalent vaccine, or do they need to have the original?
They need to have the original vaccine. That is a little bit like they need to go to A before they go B. This is following your ABCs. And I don't know if that, it may work doing this, but there again, we don't have the data. We do have the data that if you get your priming your immune system with the original vaccine is going to be important.
Okay. I think that that's really important because we do still want to reach people who've not had the original series of these vaccines, recognizing it's not too late to start them. And we know that there's a wide variability in uptake, particularly by ages, and there's not been a very large uptake in our youngest children who are available to get these vaccines, even as school has started.
Oh, absolutely. I think the uptake in children has been dismal, quite frankly.
It's, yes, very dismal, very disappointing. Um, so every time we see a booster option, I'm going to go back to this point you brought up a moment ago. Every time we see a new booster come out, there's this conversation about, should I be mixing and matching? So example, my original series was with Moderna. My booster was with Pfizer. Am I now going to be seeking out, I'm over the age of 18, am I now going to be eligible for this new bivalent vaccine from either company? Should I be seeking one of them out versus the other?
The short answer, if you're over 18, the answer is no. I tell people to get whatever it's there and whatever it's available. There's no point on purposefully mixing and matching. The mixing and matching studies that were done, and Emory was one of the sites doing the study. In fact, Emory was the lead site with Dr. Sri Edipuganti as the main investigator in the study of mix and match that was published in the New England Journal of Medicine. It's safe. There's no contraindication, but there's really no additional benefit. So don't worry about, you may want to play with it, but the reality is it's more of a game. And quite frankly, your immune system doesn't really know the difference. And that's why, again, the ACIP in their most recent recommendation did not say the names, oh, we're approving Pfizer, we're approving Moderna. They said we're approving mRNA boosters, bivalent boosters.
And again, it's so important to notice that to point out that the real difference between them is going to be if you're between the ages of 12 and 18, and that's when you're going to be getting Pfizer and not Moderna. But the place that you go get it will be certainly able to help you walk you through that. Let's talk about where we should be going to get this bivalent vaccine. Where is it currently available?
Well, there's websites you can go and find locations near you. The government has done an incredible job getting these vaccines into pharmacies, whether it's CVS or Walgreens. The idea is that 90% of Americans or more are going to be 5 miles or less from a site where you can get a vaccine. So if you go to vaccines.gov, you enter your zip code, and it's pretty straightforward to find a place that you can get a vaccine. A lot of places have walk-ins. A lot of places you have to make appointments, but it's actually not very complicated.
Great. What about getting it at the same time as the flu vaccines? So now is the time that we want to be talking about flu vaccines, making sure that people are getting those. Can we get them at the same time? If I am eligible to receive another COVID-19 vaccine, timing wise, and I'm ready for my flu vaccine, can I get them together?
The answer is yes. There's no problem with you doing that. Some people don't like to do it because one of the major side effects of both vaccines is soreness in the arm. So, for example, my wife last year, when she got both her COVID and her flu vaccine, she asked them to be placed in the same arm. She even had the joke with the pharmacist saying, "Try to put it in the same hole in my arm," because the reality is she didn't want to have both arms sore and then try to lie in bed and not be able to lie on either side because they were painful. So it's your own choice. But some people say, I don't care, and I want to have one in each arm so I know which one is painful and which one is not. It doesn't really matter. I mean, at the end of the day, make it what is convenient. If you want to space them out, it's fine, but you can certainly take them together.
Okay, so it's not going to change the efficacy of
No.
Okay. What about the monkeypox vaccination? If you are eligible to get the monkeypox vaccine right now, can you also get COVID-19 vaccine at the same time?
And again, the answer is yes. We again go to childhood where we tend to put together 3, 4, and 5 vaccines in one administration, right? So the answer is yes. And the more, I always tell people never miss an opportunity to vaccinate. There's so many missed opportunities to vaccination that we see in people. I've seen, somebody say, oh, I just was busy. I didn't get around to get my zoster vaccine, and now they're coming in clinically with zoster. I don't want to miss opportunities. And I think, we as clinicians are, especially we adult clinicians are really bad at this, and we need to do a better job. And in fact, the reason why the pharmacists have become the vaccination side of choice is because we internists are not very good at reminding people of our, your shingles vaccine, your pneumococcal vaccine. There's all these incredible tools that are out there that should be used, and we're just not using them because we forget. People don't come to the doctor. They have an issue. They say, well, I'm sick right now. I don't want to get the vaccine. So that's why a lot of the vaccination efforts have been moved to the outpatient setting, to pharmacists, where it's really easy to get your flu shot or your zoster vaccine or whatever other vaccine you need.
Let's talk about one of the reasons why you are so pro-vaccine. I am so pro-vaccine, and that is change in average life expectancy among those living in the United States. For the first time in over 100 years, we saw it fall precipitously in 2020 and then again in 2021. These are the sharpest 2-year decline in nearly 100 years in the United States, and a stark reminder of the toll exacted on this nation by the continuing COVID-19 pandemic. So some numbers. In 2021, the average American could expect to live until the age of 76. However, that is a 3-year life loss since 2018, when we could expect to live on average to the age of 79. This is disproportionately seen across the United States. And so for Native Americans and Alaskan Natives, they are disproportionately affected by this decline in life expectancy by many, many years. And in general, right now, you could expect for Native American and Alaskan Native Americans to live to the same age of an American expectation for life expectancy in 1944. That is a really, really big difference. How important has this COVID-19 pandemic been in this shift in life expectancy?
Oh, it's been huge. I mean, we've had over 1 million Americans that have died of COVID. I mean, you and I think in March or April of 2020, when people were saying, I remember the White House briefings with Dr. Fauci and Dr. Birx, they were saying, well, maybe 30,000, maybe 60,000, and most 100,000 people will die from this pandemic. We're 10 times that. We're over 1 million people have died. And this disproportionate impact of this deaths among racial and ethnic minorities. And the worst impact has been actually on Native Americans, Alaskan Natives, but also in African Americans and Hispanics. And an overall drop in life expectancy that is going to be, it's shocking to think that we've gone back to 1940. And we need to remind ourselves that most of the deaths of this 1 million deaths or more, most have happened after we had vaccines.
Right.
So they were preventable deaths. If we had vaccinated more people, those people would not be dead. They would be alive today. So our slowness in vaccination uptake by certain groups has dramatically impacted the mortality costs by COVID. So I think every time people have talked about not getting vaccinated, every time the people that have been against the vaccine, that have encouraged people not to get vaccines, they're responsible for the deaths of millions of people. And, the impact is not only the decrease in life expectancy. I mean, the real impact, the significant toll is also going to be in orphans, right? The number of kids who have lost one or more of their parents or caregivers to COVID is estimated to be close to 200,000. And that is an enormous tragedy, no matter how you look at it. This is going to be, the societal cost of that is going to be huge. And again, the value of vaccines, whether it's COVID vaccines or any other vaccine, it's enormous. I mean, we were so close to polio eradication. None of us has seen polio. You don't have to worry about polio. And now you do, right? Because all of a sudden there's, I was reading that there's 10 zip codes in New York City where the kids have under 40% polio vaccination. Well, if you had that kind of coverage, polio is going to emerge. This diseases are going to come back. So we have to remind people that just because a disease doesn't exist or you don't see it, that doesn't mean we're not worried about it, and you don't need to take your precautions about it. And the value of vaccines and the anti-vaccine rhetoric that we've seen around COVID is going to have significant impacts on other vaccines like polio, like measles, and many diseases that by this time, parents should not be worrying about.
So sad when we see some of these statistics, and we haven't even touched on educational challenges and differences in the way kids have gone to school, mental health concerns from COVID-19, all of which have been prolonged and exacerbated by our lack of vaccine uptake. And so for those of you watching today, we really hope that you will listen to the science and the recommendations to receive this new bivalent vaccine for COVID-19. If you have not recently had COVID-19, if you have started your series, this is now available for you. And we hope that you will consider taking it to both protect yourself and protect those around you, and make sure that if and when you get COVID-19, it will not be severe and it will not, again, affect your need for hospitalization and severe and long COVID, as well as your chance of death. Dr. Del Rio, thank you so much for joining me again today. We really appreciate all of your expertise.
A pleasure being with you.
For everyone watching, please be safe. Thank you.